Hey everyone, welcome back to episode 13 of Social Wellbeing Podcast. I am your host Royce Buell, and today I have three guests here with me, all of whom are about to enter professional fields in both social work and medicine. They are Matthew Ghermezi, Alanna Zhang, and Haruna Aridomi. I understand we have a case that has recently been brought to our attention regarding a client. Haruna and Matthew, can you elaborate more on this case for our audience?
Sure. Jerry is a 30-year-old single and low-income person in the city Killeen in Texas without health insurance. He is currently employed full-time at a coffee shop. He has a chronic condition, diabetes, and is not feeling well lately, although he was fine previously. He is stressed out about trying to see a doctor because he has trouble trying to obtain medical care without health insurance.
Seems to me like a challenging situation. Is there a trend that you can elaborate further regarding the demographic whom are perhaps similar to Jerry?
Yes. In terms of the history and background, looking at it in a macro scale, this has not been something that just Jerry is experiencing. It is something that has been problematic across the nation. The overarching problem is that there are still many individuals, specifically uninsured adults, who fall into the coverage gap for various reasons discussed later, and have barriers to accessing healthcare. Without proper healthcare access in the form of insurance or otherwise, individuals are less likely to receive preventative healthcare, which can result in poorer health outcomes and the burden of chronic conditions like diabetes. There are many studies that show how prevalent this issue is. In fact, studies by Ellen Moran at the University of Massachusetts have shown that even in Massachusetts, which has the lowest uninsured rate in the nation, the most vulnerable population to be uninsured are male, single, young, and low-income individuals. There are many reasons why low-income employed people are uninsured, such as the lack of coverage by their employer and falling under the coverage gap. In fact, the Institute of Medicine Committee on the Consequences of Uninsurance states that wage earners in smaller sized firms, in lower waged firms, in non unionized firms, and in non manufacturing employment sectors are more likely to go without coverage. As a worker in a small coffee shop, this precisely reflects Jerry's situation.
Matt, do you have anything else to add?
Well, in addition to the lack of coverage by their employer, low income individuals may be uninsured because they fall under the coverage gap. In fact, even after the Affordable Care Act was passed in 2010, nearly 2.5 million uninsured adults fall into the coverage gap. This coverage gap results from the state's decisions not to expand Medicaid under the ACA, meaning that these individuals' income is above current Medicaid eligibility but below the lower limit for marketplace premium tax credits. Furthermore, the Kaiser Family Foundation reports in their issue brief from November 2017 that out of all the states that have not expanded Medicaid, 27% of individuals that fall under the coverage gap are in Texas. This relates to our client because he is precisely one of these people that lives in Texas. The healthcare field is evolving even to this minute. Just recently, there has been a major political dispute between repealing the ACA by the Trump administration and expanding through universal single-payer healthcare, an idea put forth and heavily backed by the Senator of Vermont, Bernie Sanders. Pushing for single-payer healthcare would allow for coverage for Jerry and others in his situation, but on the other hand, repealing ACA would not affect Jerry in particular. It would leave more people in Jerry's situation as uninsured individuals. CNN estimates that there would be 32 million more people uninsured if the ACA is repealed.
What are the current manifestations of all these policies like the ACA?
Well, because of how the healthcare policy is currently, there are almost 2.5 million uninsured individuals that fall under the coverage gap, as mentioned earlier, with a significant proportion of these people in Texas. There are also various negative consequences of being uninsured, and a study by Michael McWilliams at Harvard School of Medicine showed that the consequences of being uninsured include having overall poorer health outcomes than individuals with insurance. His research proved that being uninsured results in decreased preventative care and services for chronic conditions.
I see. The consequences of this social problem are quite concerning indeed. In fact, Alanna and myself are familiar with the social work practice. Alanna, what can you tell us about some of the social work skills, values, and ethics in regards to what is most relevant to Jerry's case and healthcare coverage?
Yes, I most certainly can. As far as social work skills, the most helpful ones when working with a case such as Jerry's would probably be relationship building and effective use of verbal and nonverbal communication. One of the core conditions for growth and change is a good helping relationship. You cannot hope to help a client change themselves or their circumstances if they don't even trust you. And the way you build trust is through verbal and nonverbal communication. For example, showing empathy through eye contact, active listening, and body positioning. These cues would help Jerry know that you're really listening to his case and really care about him. In addition, social workers employ verbal tools such as rephrasing and reflective responding. Rephrasing is where you say something they've told you back to them to show them that you're really hearing them. Reflective responding is a way to spotlight and clarify not just what they're saying, but also how they feel about it, which serves to convey empathy and understanding. These would be especially important in Jerry's case since he is already in a compromised position, being stressed, feeling ill, and probably feeling some frustration around working a full-time job and yet having no health care coverage and not being able to do something as simple as see a doctor. Although I personally have not done any casework, these social work skills are equally applicable to me as someone who hopes to work in policy reform. Relationship building is vital not just in working with individuals, but also when you wish to advocate for and work with groups of people. You have to build trust and rapport in order to understand what it is they feel is the problem and what conditions they hope to change or achieve. In the social welfare field, we practice a strengths-based approach, where we recognize the clients as the experts in their own lives and focus on hearing them and helping them rather than simply doing what we think would be best for them. In addition, effective verbal and nonverbal communication is almost even more important when working with multiple parties, who in many cases have different interests and goals. These cases require nonverbal behavior that shows engagement with both parties, not just the one you are representing. You are unlikely to sway someone to your point of view if they don't even feel like you're paying any attention to their concerns or perspective. Empathy allows for more openness between parties and is a building block towards compromise and effective group work. Verbal communication skills, such as reflective responding and rephrasing, are also important. Reflective responding allows for conflict resolution if different parties have beliefs that clash, and rephrasing helps with the coordination of communication among multiple parties.
In addition to these skills, I think we should really mention what in particular core social work values and ethical principles are relevant to Jerry's case. Off the top of my head, I would say the most prominent values and ethical principles here are service, social justice, and the importance of human relationships. With regards to service, our primary goal is to help Jerry, who is in need of access to health care because he isn't feeling well and lacks care for his diabetes. And in turn, this reflects service to the client. The core values of social justice addresses not having access to healthcare as a social injustice, and working to change it on a macro level reflects the social worker's values of advocating for this social justice. And finally, the importance of human relationships is illustrated in that strengthening relationships between employer and employees and having a support system is an important vehicle for social change. Communication and coordination among different parties relies on emphasizing the importance of these human relationships. As it is always important to address possibilities of ethical dilemmas, some of these that I can see moving forward in this case involves a common intervention to simply empower clients like Jerry. Empowering a client might just be mistaken for simply placing the burden on the client. The social worker could be accused of simply transferring the responsibility onto Jerry. Micro interventions tend to also demand a lot from Jerry's time and effort, which might not be practical for him as he is working a full-time job and might not have time to write a journal of everything he eats. Confidentiality is also important to be discussed in that although we are using Jerry's case to promote awareness in this podcast and lobby to senators, we need permission from Jerry to do so. This is why a pseudonym has been created and Jerry's permission has indeed been granted to us. Okay, guys, as we are all young professionals, activists, and future advocates in the medical field, social work, and policy change, what interventions can we come up with to address Jerry in this social problem?
Well, on a micro scale, we can introduce Jerry to a free clinic that may exist nearby. There's actually a free clinic where Jerry lives in Killeen, Texas, called the Greater Killeen Free Clinic. They provide acute and chronic care and also specifically treats diabetes, which would be extremely beneficial for Jerry. We can assist him in preparing the required documentation like the government-issued ID and proof of income and residency so that he can get an appointment. Another way to increase accessibility to healthcare for Jerry is to work with him to find a new job that offers health insurance. Although leaving his current job will ultimately be up to Jerry himself, if he decides that he wants a new job, we can help him with resume building, writing cover letters, and interview prepping. Since Jerry currently works at a cafe, it seems to me like his strengths would include customer service and strong communication skills. Using these strengths, perhaps sales associate positions at larger firms that provide health benefits may be something to look into.
Another micro-intervention we may take is empowering our client to build a healthy living lifestyle. This may be done by working together to form a diary of daily meals, habits, and interactions, which would allow us to pinpoint the roots of the negative health outcomes, which in Jerry's case would be his diabetes. Lastly, we could build strategies for social reliance, communicating with close networks, and creating support groups to maintain health and reduce stress. The support groups can act as reminders to check glucose levels or even introduce him to new healthy foods. There are also apps that currently do this kind of thing.
Following your train of thought, Matt, on the meso level, we could also approach healthy lifestyle building through community efforts. For example, providing free education classes on preventative health practices and ways to maintain good health when dealing with chronic health issues such as diabetes. In cases like Jerry's, where he doesn't have access to healthcare coverage, he gets little to no exposure to preventative healthcare, as mentioned earlier, which can make a big difference in conditions like diabetes. With free health education classes, Jerry could more easily access information regarding diabetes and other issues without worrying about having to see a doctor every single time. Another meso-level intervention that would help Jerry out is to advocate for small businesses to provide health care coverage. In many cases, local small businesses like the coffee shop where Jerry works may even want to provide health insurance for their employees, but simply can't because it would be too expensive. In these cases, we would help them apply for the Small Business Health Care Tax Credit for small employers, which would help to offset the costs of providing health care coverage. We could also advocate for employers to provide reimbursement for employees who purchase individual health insurance, which would be a lot cheaper than purchasing a group health insurance plan, which is especially pricey for small companies.
Another clever intervention that would address access to healthcare would be to increase the number of sites of federally qualified health centers. FQHCs are funded largely by the federal government and provide primary care, some specialty services, and even dental services to underserved populations, such as those who do not have insurance or means of accessing healthcare in larger institutions. Increasing the number of sites of FQHCs can be done by recruiting more private practice doctors into an FQHC network, which can allow for more accessibility in terms of location for many uninsured and underserved clients. Another meso-level intervention that might also be taken into consideration is to create a more community programs with integrative behavioral health care in which the first 10 visits are free, and the behavioral health and medical providers work together to address the stress of the situation and the medical health care. But I think we can all agree that the recommended policy intervention level should be on a macro level, right? That way we can affect real social change for more clients just like Jerry. And as we know, one way we can approach macro intervention is through the framework of SMART goals. Haruna, why don't you start off first and just elaborate on an intervention you can suggest to address this social problem that Jerry and many other adults face?
One idea is to expand funding for the federally qualified health centers, or FQHCs, that Royce was talking about earlier. The expansion of funding would take place at the federal level within the Health Resources and Services Administration, or HRSA, under the grant budget allocated in Section 330 of the Public Health Service Act. The budget for health centers specifically was about $1.5 billion in 2017, where the money was utilized to increase the number of sites and services offered in FQHCs. The Budget Reconciliation Act in 2013 decreased the amount of funding from $2 billion to $1.5 billion previously, so an expansion specifically for an extra $0.5 billion initially would be the most logical to bring it back to what the funding amount was originally. Once that is accomplished, another expansion by $1 billion for the following year can allow for an even greater number of practitioners and services offered by FQHCs for individuals in the coverage gap. Some limitations or conditions that could affect this intervention would be budgetary limitations or the national agenda, as there may be other matters that legislative officials are more focused on. Ideally, though, this can be passed with bipartisan support as well as organizational advocacy from current FQHCs. In terms of attainability, it is possible with enough lobbying and advocacy. The Republican-dominated executive and legislative branch may seem like an issue, but interestingly, it was George Bush that put in effort to expand the HRSA budget back in 2002. If the federal budget is an issue because the funds are limited, then we can cut back spending on other, less urgent programs under the HRSA, which is what the legislatures did in 2011. To measure the success of the intervention, we can determine how much money each FQHC received from HRSA grants after the budget has passed, and compare that to the amount of money received from the same grant in previous years. One might think that congressional budget matters may be irrelevant to healthcare accessibility, but it is actually extremely relevant since the amount of funding directly affects the number and types of services that can be accessed by people like Jerry and those in underserved populations. Time-wise, the budget to fund health centers has been set until 2019, so it would make the most sense to lobby when the budget is being set for the fiscal year 2020. The fiscal year for the federal government is from October 1st to September 30th, so lobbying during February to September in 2019 would be ideal. This would allow for more time from today until February 2019 to organize and make it a strong grassroots movement. Even if the expanded funding is not passed for 2020, we can continue to advocate for expansion throughout each fiscal year in the next 5 to 10 years to come.
I have an idea for a SMART goal as well. Specifically, I hope to advocate for universal health care provided by the United States government to all individuals nationwide within the U.S. This can be done through a federally administered, single-payer healthcare program. Single-payer healthcare is a healthcare system financed by taxes that cover cost of essential healthcare for all residents, with costs covered by a single public system, hence single-payer. This means comprehensive coverage for all Americans covering the entire continuum of healthcare. This plan would cost $1.38 trillion per year, but with our proposed taxes, it could definitely be done. In the current political climate, it would be difficult to pass all this legislature as the House and Senate is ruled by Republicans who are against raising taxes, but in the coming years it can be done. This proposed plan would greatly reduce healthcare disparities within the U.S. The effectiveness of this plan could be measured by looking at the number of uninsured individuals in the U.S. This number should drop to zero shortly after implementing this legislation. The eradication of uninsured individuals would also result in improved health outcomes for the groups that are currently affected by healthcare disparities. Although this would definitely be a difficult goal to attain, it is possible through lobbying and advocacy. There are currently a handful of senators and representatives that support Bernie's bill, but not nearly enough to get it passed. I believe that lobbying would show the senators and representatives that don't currently support Bernie's bill for universal health care what it is about and teach them that it would positively affect our nation. This issue is currently very relevant. Through my current research, I have seen the horrible effect that healthcare disparities have on individuals, and I believe that universal healthcare would reduce this disparity greatly. I noticed an unmet need in which universal healthcare would meet this need within the U.S. This would help both our clients and millions of other individuals around the U.S. receive healthcare. Helping millions of individuals gain access to healthcare is definitely worth the time and effort, but with the current state of the Senate and House, it might not be the time to push for the legislation to be passed. It might be only right to gather support until the next election where the makeup of the House and Senate could change and allow us to get the legislation passed. In order to work towards this goal, we need to follow a timeline. Today, we need to educate ourselves about countries that currently have a successful universal healthcare initiative and extract the areas which we could use. 6 weeks from now, we should lobby local senators and representatives who currently do not support the Bernie bill. 6 months from now, I hope to use my social capital and political influence as a legislator along with the 44 Democratic senators to continue rallying support. 6 years from now, I hope to gather enough support from the Republican Party as well as other organizations to have a strong backing and push to get the necessary legislation passed.
Well, that's great. I have a suggestion that was also partially addressed by the ACA in 2010. Advocate for expansion of Medicaid to cover 138% of the federal poverty line of individual adults as a mandate for all states. This goal would allow people who fall in the coverage gap within the states that have not expanded Medicaid to be able to attain health insurance and preventative care. Like I said, this would be located in the 19 states that have not expanded Medicaid under the ACA, which includes Texas, as that is where the client Jerry lives. A barrier that is worth noting is that the administration that has the most vote in the three branches of government is the Republican Party, whom in the past has been the opposition in expanding Medicaid to all 50 of the United States. The legislation that we will propose will be measured based on the number of people covered on Medicaid in the 19 states that have not adopted the expansions. It will also be measured through the number of states that adopt the expansion. If we talk about attainability, I believe this goal can be accomplished by lobbying senators in the 19 states who oppose Medicaid expansion. And if this is to be considered in the next 10 years after the current administration, it becomes much more feasible as there has been growing public support which can be seen through recent social movements, grassroots organizations, and advocacy by 17 current senators. This is relevant to accessing health care coverage for single working adults in that it will allow them to be covered under the Medicaid expansion from the ACA. Now is at least the right time to gather support for this legislation for the midterm election and 2020 election. If the administration changes, there will be more support for legislation that increases the FPL eligibility. In the current socio-economic environment, this further expansion of Medicaid is extremely applicable. Adopting the expansion would save the states money in that states not participating are foregoing billions of federal dollars that could provide their residents with health care. In total, implementation can be fully achieved within the next 4 to 8 years. Today, one can educate oneself on the legislation and history of Medicaid, understand how Medicaid works and who falls into the coverage gap, understand how accurate the FPL is and what it measures. In the next 6 weeks, one can create a club, hold a community meeting, advocate, or become an activist. In the next 6 months, I can see someone lobbying their local legislators for a policy that increases the FPL income eligibility, petition, educate, use grassroots organizations, contact your local congressman, run for political office, or have conversations with family members about the topic of Medicaid expansion.
Another intervention that would help Jerry and others like him would be to advocate to change the employer mandate, specifically to require all employers to offer health insurance to their employees. The current mandate requires only employers with 50 or more full-time employees to provide affordable health insurance. In 2016, 74% of non-elderly uninsured employees worked for an employer that did not offer health benefits, and the majority of these employees worked for small businesses who are not required to offer coverage. Thus, relevance-wise, advocating to expand the employer mandate to all employers would help ensure that people like Jerry won't fall through the cracks. Advocacy would take the form of creating a reform bill and lobbying for it on the federal level to senators and House representatives who would vote on it. The limitations to this reform are not being able to address uninsured people who are not employed or work part-time or contingent labor. However, it would still insure millions more people, and it is very measurable by simply seeing if there is a decrease in the number of full-time employees without health care coverage. As far as attainability, the biggest issue would be that expansion would disproportionately disadvantage smaller companies with smaller revenues, some of which undoubtedly wouldn't be able to afford to provide all their full-time employees with health care coverage. In addition, group insurance plans are much more expensive for smaller companies, with much higher deductibles. To combat this, we can also advocate to expand the Small Business Health Care Tax Credit, which is a tax credit available to companies with under 25 full-time or 50 part-time employees that provide health care coverage. The expansion of this credit would qualify employers who have under 50 full-time employees and would offset the costs and burden that the small businesses might face when providing health insurance. Unfortunately, time-wise, the next few years will be a very unfavorable political climate in which to try to pass more liberal health care reforms. However, this time can be used to draft the reform bill and reach out to senators who are likely to support the reform and gain their vote. Getting it passed in the next 3 years is highly unlikely, but definitely possible in the next 7 to 11 years if a Democratic president is elected. Social reforms take time, but it is the responsibility of all of us to fight for social justice.
And on that note, it is closing time here on the Social Wellbeing Podcast. I would like to thank my guests Matt, Alanna, and Haruna for stopping by for this episode. And as always, I am your host Royce Buell signing off and wishing you all happy holidays.